Moving on to our fourth technical session. The topic for the fourth technical session and the last one for today would be what healthcare desires from machine learning and artificial intelligence. I would take a minute to thank our sponsors again for the summit. Our title sponsors are Kalinga Hospital, Apollo Group of Hospitals, Amri Hospital, Medica Bazaar. Our media partner is Kanak News. We are supported by Ashwini Group of Hospitals, Sun Diagnostic Center, IGKC Multi Speciality Hospital, and the only distributor, Rabindra Surgicals Private Limited. The fourth technical session would be the session chairs for the fourth technical session would be Mr. Devesh Sinha Sir, Advisor, IT and Startup, ICC Odisha State Council, and CEO, Cozentus Technologies Private Limited. Dr. Rohit Jaiswal, Group Medical Head, Amri Group of Hospitals. The speaker for this technical session will be Dr. Sujoy Kar, MD, Chief Medical Information Officer and Vice President, Apollo Hospitals Group. I open the stage to the session chairs and speakers.
Very good afternoon to all of you. I think we are running a bit late, and I'm sure we are holding you for the lunch. So we'll try to do as fast as possible and justice to this session so that your wait is worth. So this topic here is we are talking about what healthcare desires from AI and ML. Right. I come from a technology background. Basically, I am an entrepreneur with the IT services company we run, but we don't do much of the work on the healthcare side. We are primarily into logistics solutions for the companies all around the world, mostly in the Europe and North America. So when we talk about the AI and ML, I think my role should be, before I hand it over to Dr. Kerr, to explain a bit of AI and ML, what it means in terms of the technology. I'll try to give a very simple analogy for the AI ML to the how the human intelligence and AI ML are similar. So when we talk about human intelligence, right, how do we make decision? How do we think? There are a few factors which come in the play. And the first, I would say that genetics come in the play. Then how we are surrounded, like what kind of exposure which we have got in our life, right? And most of our decisions are made based on the exposure we have. So what happens on the background, when we get the exposure to the different areas, I'm sure that what we are getting is basically we are collecting the data. We are collecting data from our experiences, what we are seeing, what we have been exposed to, and our vision or intelligence come from there. So actually our brain is the supercomputer, and which basically processes the data in a quick, such a short time that we don't realize, but we act based on our past experiences which we have collected the data. And AI ML is no different. So if I explain AI, it's artificial intelligence. What it does is it basically is a model by which it learns by itself. And when we talk about the machine learning, which I'll come later, so what happens that machine learning is just a tool to, or rather the means to teach AI, right? It is like a parents which used to teach us in the childhood, the similar kind of a thing which come done by the ML. So when we talk about the ML, right? So what happened that we collect the data. Today, what has happened that in the data world, it has exploded with the data. Like we have so much of data all around. Everything is every device is collecting data. Be it our mobile phone, be it our watch, be it our any activity which you do. Those data is getting collected. So similarly, the healthcare industry also, you have a plenty of data now. So what happened that these data, based on this data, we have a huge set of data, large data set by which we are able to analyze and able to put into the system or the model based on which we are able to take decisions. So that is what the primarily AI is, right? And what happened that as we keep adding data into our model also improves and they are able to take the better decision, right? So these models are very adaptive model, like our brain. The decision which you would have taken probably 20 years back, you take very different decision in the similar kind of a situation as well. Why? Because we mature, we have more data to process. Is what the AI and ML does today as the maturity process. I'm trying to explain very simple terms. I'm not going into the healthcare at all, so that Dr. Kerr will talk about it more. So the important part about the use of AI ML is that the prescriptive as well as predictive, right? We should today in a situation, we can predict that what disease I'm going to have down the line. And that is the power of the AI and ML today. And that is what we should focus on. When we talk about AI, most of the time it comes as a negative connotation that it's going to take away my job. So I believe that not the case. What we should use is AI and ML or AI to say that how it is going to aid us giving the better service, right? More accurate and precise treatment to to patients. So that is how we can use this AI and ML. So with this understanding, I would like Dr. Kerr, who comes from the industry of healthcare, can talk a little bit about more specific use cases, what kind of things on the clinical and non-clinical side happening in the AIML, and then to elevate the question and answer session. Mr. Jashwal is there. Of course, he will be the helping us in terms of some question and answer as well. So over to Mr. Dr. Kerr.
Given a choice, if I had to choose technology versus lunch, I'll choose lunch. And therefore, I know your vision and know your perspective, and that's why, um, yeah, camera, please. I get a little nervous when you are just standing there and doing. I have some heuristics which I have to, you have to pardon me with this. This set of slides I was asked to present in Indian Technology of Kharagpur, where I am a faculty for the last 6 years. And also tomorrow I'll be back in another institution, Indian Institute of Management, where I am Calcutta, where I'm teaching for 7 years, and at ISB, where I run this course for 2 days. I'm just going to talk about. I gave this presentation for less than 15 minutes in CII last week, and I'm going to make sure that I give it less than 10 minutes here, so that I don't stand between you and lunch. The reason why I'm telling this is because you heard it in the morning or the previous sessions that technology is going to take a lot of center stage in the way we take care of our patients. I would not put it that there was a comment somewhere that doctors are not God. Technology is not the panacea for all the problems we have in healthcare. It is, however, a way to solve these problems in a more structured design thinking or systems thinking way. And again, if you want to know more about design and systems thinking, welcome to my classes in any of these institutions, or in IIT Kanpur, where I'll be again going there in a few days. When we study AI/ML, we have these 5 fundamental problems, and the 5 fundamental problems are: how do we make AI more relevant in healthcare? There was an example given of IBM Watson. IBM Watson was not trained with Indian data. IBM Watson didn't have a cross sections of studies across different cancers to actually say that their outcomes and outputs were very relevant in a randomized clinical trial. Or they have seen this in mammoth number of patients that we see going forward worldwide for patients who get treated with cancers. And that is one of the main problems with AI adoption across the world, because a lot of physicians do not believe them. Do not believe them because they do not know what would be the outcome or output. And there are many reasons in technology hidden there, which actually says, yes, there is a trust issue, particularly in the terms of accuracy. You know, whenever traditionally how doctors have looked at accuracy, they've looked at sensitivity, specificity, and stuff like that, positive predictive value and all. And suddenly when you move to AI ML, you begin to talk about area under curve, accuracy, precision recall curves, and other things like that. How do you interpret this for a decision that you have to take at a point of time in an emergency room? We heard the example of a stroke. How do you then go about what protocol that you are going to tell? How the clinical decision support system, which has an accuracy of 77%, but an AUC of 91 or 0.91, is effective in treating that patient? We still don't know. The other thing is, whenever you build AI, and I'm going to spend a little bit of time on the slide, when you build AI, you build with certain set of data. But when you start using them in the ground, you begin to confront with a different set of data. And the reality comes back to bite you. And that is where what we call as a model drift, suddenly you have to then look at continuous feedback that would come and try to improve your algorithms over and over again. Then there is a question that, do you contextualize AI in a way that you start using AI in certain terms where it was not meant for? Do you then take certain things like you can predict discharge 24, 48 hours before, and we work with MIT on that project? What do you do with that? Even a doctor or a patient knows that the patient is going home in next 24 or 48 hours. What do you do with that? You know that the patient is going to get shifted after a surgery to an ICU. What do you do with that? How does that knowledge and information impacts your dashboards, impacts your utilization in the OR or utilization in the ICU? Those are the kind of things that you have to really think before you do that. And we did a mistake. You know, if you look at Google papers, and I have very good friends in Google, I work with them all the time. But they have traditionally pitted people against technology. They have pitted all of their AI algorithms against doctors and said, you know, we can do better than 500 doctors. We can do better than these radiologists and all and all. If you look at what MedPalm is doing, it is just trying to find out how good a doctor goes and passes an USMLE examination. Why? Why would you build a technology which pits you against a human being? Technology is always a supportive, subversive stance that it has to take in order to support individual, not to stand against it. And when you do that, you actually take a wrong way of looking at it. And we know these technologies are not good, and these are all from the MIT Tech Review. And if you go and look at these papers, you'll see that the first one was a dermatology app which worked exceedingly well when it came out for Caucasian population. It was diagnosing all types of dermatology cancer with a very high accuracy. But when it moved to people with color, no, it was not doing good at all. And then there were people in one of the very top hospitals in Boston where you had algorithms which would deny admissions or readmissions to people with color when, you know, because the algorithm could not detect that they could come back with readmissions criteria. Or even you see these days elderly gentlemen, 75 years old, like my father, who lost his wife. I lost my mother about 4 months, 5 months back, who now plays around with gadgets and in many cases looks around about his own health or heart failure. What is the kind of information are we passing on? How is, you talk about in all your hospitals, you talk about IPSG goal number 2, where you talk about importance of communication. How do you talk about communications between a machine and human handoff? And how does it happen in the terms of conversational AI that you talk about? Those are burning questions, my friends, when you are going to accept, AI in the mainstream. This is an example of Google where they worked exceedingly well in retinal images for diabetes when they were working in their labs. But when they put it onto the ground, the main problem, internet connectivity on the last mile. So you had problems in actually delivering what you were committing. And I always, when I teach at IIM, I talk about what you do in terms of operational backbone. You commit operationally what you commit digitally. And if you are not operationally able to commit or do what you commit digitally, there are problems. The other thing is the interesting science of bias. I'm going to talk about bias in World Summit for AI in Netherlands later this year, where we have some studies to show how ethnic biases, geographical biases, gender biases, biases about people adopting technology can actually take away the whole essence of putting in AI. Now, if I have frightened you a lot about how AI has to be used in the healthcare setting and what are the perils of this, I'm going to talk about what we do about all this. And recently, Dr. Sangeeta Reddy and I published a paper on a framework that we use at Apollo Hospital. We call it EASE, where we have ethics, adoption, suitability, and explainability around AI to actually see how we design and develop these things. This is available publicly. So we look at the first thing, which is around the ethical consideration, where you bring in the ethics of developing AI and the ethics of medicine together in safety, inclusivity, fairness, effectiveness, and all of these together in all the cauldron and say, what is the ethical framework that you would like to have in terms of clinical AI? But you don't make clinical AI just for fun. You have to adopt it. So what are your interoperable structures? What is your benchmark? What is your patient safety perspective that you are bringing somewhat of this to bring into the whole perspective? And then then you bring in, why have you developed it? What is the public health need? What is the need of the acute care that you bring in to actually build this AI? How do you address bias? And of course, the important pertinent question of human-machine handoff. But all said and done, we also know, particularly certain elements of machine learning, which is what we call as deep learning, which can turn as black boxes. You do not know what the outputs are, and therefore you do not know how they are committing into that. So how do you explain your AI, or how does AI explains itself to the doctor so that the doctor can go and explain it to your patient? How do you build that trust over a period of time? I'm going to quickly run. This is an architecture slide that actually shows how do you take data from your organization, go about normalizing the data, use the semantics, move around in the data quality, use ethical frameworks, then move on to certain elements like, go up the ladder, looking at the very minimum AI or ML structures and then or tools and go up the ladder. And then once you have this, take your algorithm, build the API out of it or application programming interfaces out of it. Integrate this with clinical decision support system, which will say what next to do. Once you've done this, and that's a lot of work, you publish it, you take this and put it into a container in one of the clouds, right? Like Azure, GCP, AWS, wherever you are comfortable, and take it to as many people around the world. We today have about 24 people with whom we work across US, UK, Netherlands, Middle East, Southeast Asia, and Australia to actually validate the algorithms that we are working on. At some point, so what are the algorithms that we are working at this point of time? The first one is, of course, on the conversational AI, and I'll just show you a video very quickly. The second one is on the disease progression models, on the risk models, where you are able to tell in the disease progression what would happen to the individual over a period of time. This third one is where very commonly AI are used, as in chest X-ray, medical imaging, ECG, and some of our latest ECG papers have been now accepted by American Heart Association for publication and presentation. And the number fourth, where you actually look at early warning sign, empirical antibiotic recommendation systems, and then take all of them to see how you use them in throughput optimization at the hospital. How do you improve your length of stay? How do you decrease your readmissions? How do you reduce your wait times and all of that? So it's not just clinical all the time, but clinical operations in that. I have a video. Uh, the video sound is not there, but I'll still play it for at least 1 minute. It actually talks about, how we are using the clinical intelligent engine, which we launched in our Founders Day in February this year. So what does the CIE does? CIE takes in the symptoms of individuals. It's been developed with about close to 40 years of patient journeys at Apollo, and with 6 lakh journals layered with AI. And what it does is it makes the entire clinical process more intuitive, efficient, and accurate, and build them all together to give what we call as a symptom inquiry. And you can go and see this in Apollo 24/7. The newest version is about to be released, which is less algorithmic and more intuitive. And then you move on and see how we can generate a case sheet in the interactions with the patient, where you get everything around the patient's input, gives a differential diagnosis, gives a way by which you would say recommendation on labs, and analyze this case with generative AI to give you a history like that. Now, we have been working, generative AI is not a new thing for us. We have been working with generative AI for past 3 years now. I'll just quickly go and tell what it does for the patients. So for the patients, it leads to discovery of symptoms, looking at the labs, imagings, and others. For the doctors, it builds an automatic case sheet summary, so that when the patient is waiting, you can engage them on either the virtual network or in the physical network, and the doctor has a summary before you actually see them in the OPD or see them online. The second one is, of course, the work that we have been doing in cardiovascular, liver, COPD, diabetes, kidney, and of course now moving into stroke, osteoarthritis, and migraine and all. We now have about close to 750,000 users who have taken this within Apollo, and just last month we have had 10,000 users taking it on the Fitbit. So we've started building algorithms within Apollo, and we now give it to Fitbit and Apple Watch to actually use them on the prospectively, including patient sleep, patients' daily activities, diet, and all, which comes in as very important factors to actually say what are the chances of their developing cardiovascular or CVA or kidney diseases over a period of time. This is a work that is now AIMS wants is from us. It's been validated by King George Medical University. It's validated by Imperial College London, and of course Cardiology Society of India, American College of Cardiology, and lots of other institutions at this point of time. The other one I wanted to show today was about antibiotic recommendation system. We all struggle with the antibiotic choices. So what we did was take about close to 260,000 culture and sensitivity results from 20 hospitals over the last 4 years, and hammer them together to actually, use a machine learning and a recommendation system, much akin to what you have in your Amazon or, or even Netflix, and then provide, if you give certain symptoms and where you are, including Bhubaneswar. Bhubaneswar is one of the very important hospitals for us here. If you take that data and tell patient's conditions and all of the others, where the patient is, OP, ER, IP, how many days in IP, and which specimen you are sending, we can tell you what are the top organisms, top 3 organisms, and what are the top 3 antibiotics for each one of these organisms. which, by the way, is something which helps in the overall organizational antibiotic stewardship program. What I'm running here is actually the cascade of the four early warning signs. And there are algorithms now that we have developed where we can predict, ward to ICU transfers, early warning sign, pre-anesthesia, and what you're seeing here in a handheld device format is when an anesthetist takes all the requisite amount of information while doing a pre-anesthesia, we are able to predict what would be the duration of surgery, what would be the duration of blood loss at an accuracy of 93%, and where the patient would be going after the surgery is done. So not only it captures a lot of things for the patient's, from the patient's pre-anesthesia perspective, but it also gives you a cue how you are going to tag this into dashboards for the OT, dashboards for the ICU, and of course for the blood bank as well. Okay, I prolonged my talk. Now, many of you are beginning to use generative AI, and I have 3 cautions for you. I work very closely with Microsoft. I've been working with 6 years with Microsoft at this point of time. And, last week when I met them, they are gung-ho about generative AI. And I said, you have a solution where you can actually build discharge summaries from any of these patients, but all discharge summaries across whichever comes through OpenAI would actually look same. Then how do you are going to make a differentiate between what comes from Narayana Hridayalaya or Apollo or from Kalinga or Amri? And that is where you have to use what I call as your differentiated databases. And your differentiated databases are the ones where you have your entire clinical acumen put into your discharge summary, and it comes out in the way it should. However, also be careful about how you use generative AI. I want you or recommend you to look at the way generative AI or GPT plays chess. First 30 seconds, wonderful. After that, it goes berserk, and it's going to do with you as well. And so therefore, it's very important. And why it is doing that? And that is called prompt brittleness, which is about, the breaking of sequence of the prompts when you are actually using it over and over again. And that starts giving you wrong information. Now, unchecked wrong information going into your discharge summaries have a lot of perils. Imagine that it could be a patient safety issue. And the other thing is, of course, you've heard this term. Gyani sir was talking about mental health, and I'll talk about mental health of AI, where people start hallucinating or models start hallucinating. Hallucinating, by the way, from the scientist perspective is a very good thing because model is trying to learn something by itself. But the outputs are underdetermined and absolutely unresponsive, bizarre, and therefore you have run again in the peril in terms of patient safety. This is my last slide. Then, how do you go about in doing AI in healthcare if you have so many problems? First thing is you need to put AI, the narrative around the AI is something which is not a substitute, but something which would have, help clinicians to deliver better care. And then you move on to certain things which you would actually bring in. How do you then go about in building data consortiums across the world, within India and across the world, where you can compute your algorithms and see how good they are? Now, to do this computing, you need money and you need computing power on the Azure stacks or on the any cloud stacks. And once you have done that, you will be in a situation where you will be able to mimic or simulate what happens to the patient when you give a particular drug outside the body, test it, and then go and give it. That's what we call as digital twin. But we are still far, far away when machine takes over. And someday it will. And it will take over when we have this perceptrons, their entire ways by which machines would take in this data, become attentive and start responding to this. Possibly I will not live to see that day, but my daughter will. Thank you very much.
Thank you, Dr. Sujay. It was wonderful presentation and very
Yeah, Sujay. A very complex topic, you have compressed it, I don't know, 15, 20 minutes as, and just a minute of it. As Devesh said, data. Data is the building block. That is exciting, considering the Indian ecosystem. And AI is super exciting. But I would say that for India, I think we have to differentiate it into two categories. One is for the masses and one is for the individual healthcare. We're talking about healthcare to take it up. And Dr. Gyani is there. I would say, sir, the NDHM, the National Digital Health Mission, is a very positive step. And let's make it perfect so that we implement this AI in that. And it is going to be there in the fact that we are going to get so much data so that, and especially considering the communicable diseases in India, which is a very large burden, we can do wonders if we put AI into that. And as far as individuals are concerned, I am very happy and excited to see what Dr. Sujoy has presented and Apollo is doing. I would like to get in touch with you later part and see. But at the individual level also, I would say that each and every hospital and institution can also develop their own homemade AI. But the fact of the matter is that you have to digitize your process, your operations. And you can learn so many things within your ecosystem. So definitely a long way to go. But yes, very exciting future, and let's work on it. Thank you very much.